The Epilepsy Foundation, in partnership with the American Association of Neuroscience Nurses, is pleased to share with you an educational webinar providing an overview of the basics of seizures and epilepsy in children and adults. The mission of the Epilepsy Foundation is to lead the fight to overcome the challenges of living with epilepsy and to accelerate therapies to stop seizures, find cures, and save lives. My name is Dr. Elaine Kiriakopoulos, and I would like to extend a warm welcome to everyone who has joined us today and provide you with some instructions regarding today's webinar format. During the speaker presentations, all phone lines will be muted. You may type your questions into the question box on the GoToWebinar panel on the right-hand side of your screen at any time during the webinar. Your questions will be presented to the speakers at the end of the webinar. Today's webinar is intended for educational purposes. Today's webinar is made possible through a cooperative grant from the Centers for Disease Control and Prevention and their support of the National Epilepsy Education and Awareness Collaborative. A quick reminder that if you are going to be requesting continuing education credits, completion of the entire evaluation is required. AANN will follow up with participants with instructions on how to obtain credits within 3 to 4 weeks of completion of viewing of the webinar and submitting your evaluation. We are so pleased to have with us today Ms. Madonna Pluger and Dr. Erin Fesky, who will lead today's learning. Madonna Pluger is a neuroscience clinical nurse specialist and certified neuroscience nurse at the Barrow Neurological Institute, a Level 4 Epilepsy Center. She serves on the board of directors of the American Association of Neuroscience Nurses and has spoken locally, nationally, and internationally on the topic of adult epilepsy. She has achieved fellowship in the American Epilepsy Society in 2018. Welcome, and thank you for sharing your time and your expertise with us today, Madonna. Dr. Erin Fesky is a pediatric nurse practitioner and certified neuroscience nurse at Children's Mercy Hospital in Kansas City, a Level 4 Epilepsy Center. She serves as the annual planning committee chair for the American Association of Neuroscience Nurses and has spoken locally, nationally, and internationally on the topic of pediatric epilepsy. Erin, welcome, and thank you for sharing your time and your insights with us today. And I'll go ahead and turn the webinar over to you to get us started.
Great, thank you, and welcome everybody. So today our objectives are going to be to identify some of the common seizure types in different age groups based on the International League Against Epilepsy, the ILAE classification. We're going to talk about some care principles for use of the anti-seizure medications in children and adults with epilepsy, and implementation strategies for early identification of children and adults with drug-resistant epilepsy. And finally, we're going to talk about seizure first aid with the goal of feeling confident in teaching our patients and families about seizure first aid. Next slide. So when we talk about epilepsy, there are several critical gaps in the treatment. And the big challenge is that the number of people with active or persistent epilepsy has remained unchanged for years. Patients are still receiving treatment on older AEDs or anti-epileptic drugs where they still struggle with side effects. And there is a significant delay in referral for epilepsy surgery despite new surgical techniques improving safety and outcomes for patients. We also know that identification of patients with drug-resistant epilepsy isn't consistent, and there's limited access to providers and treatments for epilepsy, which may be higher in some areas. Next slide. So our goal is to move the needle on that, to educate us, to educate those around us, our families, our patients, and empower our teams to use best practices and educate everyone who may come in contact with patients with epilepsy on the proper first aids so that we can be managing patients appropriately. Next slide. So we talk about epilepsy, it's important to understand that it's a brain disease and it's actually a family of syndromes. So to say that someone has epilepsy is not a super specific term because it could mean a whole lot of different things for different families and different patients. It's important to know that epilepsy is 2 or more unprovoked seizures greater than 24 hours apart. And there's a lot of important parts of that statement. So 2 or more. So everyone gets 1 free unprovoked seizure. But after that second seizure, that's when we consider someone to have epilepsy. They have to be unprovoked, meaning no fever, no head trauma, which suddenly results in a seizure. And they have to be greater than 24 hours apart. Alternatively, someone could have 1 seizure and be identified as high risk of recurrent seizures. High risk being someone who has a greater than 60% chance of a second seizure. And this came about in the newer ILAE definition in 2014 to allow for some of those patients who had 1 seizure, but we knew we're going to be at higher risk for further seizures. And then the other is a patient who's been diagnosed with an epilepsy syndrome. If you meet one of those bullet points, that's when you meet the diagnosis of epilepsy. Now, epilepsy, seizure disorder are often used interchangeably by our families. It's important to know that seizures are not always due to epilepsy, but epilepsy and seizure disorder are often used by our families interchangeably. Next slide. So the short answer to how common is epilepsy is that it's pretty common. So 3.4 million people in the United States have epilepsy, and 1 in 26 people will develop epilepsy at some point during their lifetime. Next slide. And epilepsy doesn't discriminate. So anyone can have epilepsy. It's regardless of age, race, socioeconomic status, geography. It is all over the world. It hits our young, our old, our teenagers. Epilepsy can impact anyone. Next slide. Now this graph just shows some of the incidence of epilepsy by age, and it's important to note that when you see that green line, the generalized epilepsies, you see that it's much higher in young adult, in children and infants than the partial onset, and partial increases with age. So we have these 2 spikes when we talk about epilepsy. We have a spike in childhood and then a spike in our older adults. Next slide. So we talked a little bit about epilepsy, but what is a seizure? So a seizure is a symptom of a disturbance in the brain. So it is an abnormal organized electrical discharge that happens from a complex chemical change in the brain cells. These organize in a manner so that you get physical manifestations or changes in consciousness. Now it can be a manifestation or a symptom of multiple different things. And so what I often talk about with families is it's like that you see a fever in an illness, right? So you see a seizure and you're treating the seizure, but it could be a result of multiple different things happening under the surface. And so we think about provoked or unprovoked seizures. So provoked seizures are things that are provoked or caused, like a fever, a brain injury, versus unprovoked, where there's no sudden change to have triggered that seizure. Next slide. So we approach seizures based on the ILAE, or the International League Against Epilepsy classification. And this was updated in 2017, which is why you're going to hear a lot of different terminology thrown around. And it's because the terms change and evolve as we learn better ways to classify things. And so it's important that we are using the most up-to-date terms when we're talking about seizures and epilepsy. So there's 3 major branches. We have focal onset, generalized onset, and unknown onset. Focal onset meaning the seizure starting in one location in the brain. It could either stay in that location or it could spread. Generalized onset meaning the seizure starts all over the brain at the very onset, at the very start of the seizure, and then unknown, quite literally meaning we're not really sure where it's starting and how it's starting. Now, I said starting because we, when we're classifying seizures, care about how they start, not necessarily how they end or how they evolve in our classifications. So focal onset seizures, those seizures that start in one location of the brain, there's 2 subcategories. So we have our aware or our impaired awareness. Aware meaning that the patient's cognition, their ability to interact with their environment and the world around them has not changed, versus impaired awareness where they have a change in their ability to interact with their environment. Now, those could be motor or non-motor, meaning they could move or have movements and jerks, or they may not. And it may start and then it may spread. So that seizure may start in one spot and then have bilateral tonic-clonic, meaning it spreads to both hemispheres of the brain and involves the entire brain. When we look at our generalized onset, you see that always has impaired awareness, because once you've involved both hemispheres of the brain, you're going to have impaired awareness for the patient. And those could be motor seizures, where we think of our tonic-clonic seizures, our everything shaking and jerking kind of seizures, and then our non-motor seizures, where we think about our absence seizures. And then in that last branch, our unknown onset, we could see either motor or non-motor. And again, these are seizures that we cannot classify if they're generalized or focal based on the current information that we have about that patient or about their seizures. Next slide. So when we talk about focal seizures, I mentioned a little bit that we first want to think about the level of awareness. Is the patient aware? Are they unaware? Or is the seizure so brief or no one was able to interact with them that we don't know their level of awareness? And then we want to assess their motor movements. Did they have loss of movement? Are they having abnormal movements, excessive movements, autonomisms, which are those rhythmic, non-purposeful movements? We see lip smacking or kind of picking behaviors with their fingers. Are they having changes in their sensory perception? Are they reporting anything to you about that? Are they having cognitive or emotional changes or autonomic system changes? And we're going to play this video for you briefly that shows focal seizures.
I have epilepsy, and I'd like to share my seizure with you. I want you to see it so that you won't be afraid. When you have epilepsy, you ask yourself, when will the seizure happen? Who will see? Am I still me?
So as you guys can see during this, she's having alterations in her facial movements. She's having repetitive, not purposeful movements and is not interacting with her environment. So that would be a focal seizure, unaware, meaning we have alteration in our awareness. And it's a motor seizure because she's having some excessive movements and autonomisms. Next slide. So then we talk about generalized seizures. And remember, generalized seizures are the seizures that involve the entire brain at the onset. And as you can see by this slide, there's a lot of different types of generalized seizures. And so people who maybe have not had a lot of exposure to patients with epilepsy, we often think about those tonic-clonic seizures, which were formerly called grand mal seizures. So those are the seizures where someone stiffens, they have a tonic phase, and then a clonic phase where everything jerks. And so if you look down this list of terminology, all of these have been updated so that they literally describe what the body is doing. So tonic is stiffening, atonic is loss of tone, myoclonic is a muscle jerk. And so those terminology are really helpful in defining what's happening because it really outlines what you're going to be seeing. And then you see with our non-motor absence seizures, we define them as typical or atypical, and then you may have that eyelid myoclonia associated with them. And so we just try to give some descriptions as to what's happening with patients during those seizures. Next slide. So when we talk about seizures and epilepsy, there's lots of different things, and families will come and say, well, they said I have focal onset seizures, but does that mean I have epilepsy? And so one of the reasons that we wanted to share this slide is to really show you guys how we walk through this. So you want to identify the type of seizures that patients have. Do they have focal seizures? Do they have generalized seizures? And that's going to help you define their type of epilepsy, if they have focal epilepsy or generalized epilepsy. And based on all of that information, we may at that point be able to identify an epilepsy syndrome that a patient has. And that can be helpful in identifying potential treatments, clinical course, or expectations for a patient. And so if someone comes and says, you know, I have generalized epilepsy, but I don't know what kind of seizures I have, that will give you a bit of information. And it's just important to see the flow of how that all works under the umbrellas. And it's about getting more and more specific to get more and more information for the patients. While we're identifying all of that, you can see that etiology and comorbidities are happening in parallel. And so we're looking at all of these things for our patients. Next slide. So some of those examples of epilepsy syndromes, things you guys may have heard. And when I'm looking at epilepsy syndrome names, it's helpful for me at least to remember that a lot of these terms are French, at least in my head they are, and that's how I know how to pronounce them. So Dravet syndrome is that first one, and that's a refractory epilepsy due to a genetic mutation, commonly SCN1A. And this one has gotten a lot more attention recently because of some new medications that are being trialed for Dravet syndrome. Patients have multiple seizure types, they have developmental delays, and can have refractory, meaning drug-resistant epilepsy. Childhood absence epilepsy is one that typically responds to first-line treatment for most patients. Patients often stop having seizures by adolescence. This is one that they typically outgrow. And it responds to those common medications. These are kids that often present to us at school age, and it's often teachers that notice that maybe someone's having lip smacking, they're staring a lot, they're really struggling, and so that's often when that is caught. Infantile or epileptic spasms is a rare epilepsy. It could be genetic, it could be structural, it could be idiopathic. It's a result of multiple different etiologies, but it results in developmental decline and a very typical seizure. That's something that once you guys see, you will recognize it in other places. And it's an important one to address when we're talking about early treatment for patients. And then GLUT1 is a glucose transporter deficiency. So this is an interesting one because it resolves or improves with the use of the ketogenic diet. And so that's another one that's important to understand, that some of these epilepsy syndromes really do impact what we're going to do for patients. And so it's helpful to see if we can identify where a patient falls into. Next slide. So this is that video I mentioned of infantile spasms. And this is a young child who presents to the ER with these events. You can go ahead and play the video. So you can see we have repetitive, stereotypic movement. Knees draw up, arms extend. They almost have a facial grimace with this as well. It can be confused with reflux, but these patients often cluster, so they'll have multiple events. You see mom's trying to hold his hands and he will continue to do it. You get a little bit of circumaural cyanosis for him as this progresses. And this is one of those epilepsies that we want to make sure that they're being assessed by neurology early, so that we can intervene as needed for these patients. And with that, I will pass it on to Madonna for adult.
Thank you, Erin. Thanks for that great introduction and overview. So we'd like to spend some time to talk about the importance of location when it comes to the epilepsy syndromes in adults. This slide depicts the different locations of the brain that are common with the type of epilepsy associated with the brain location, the lobe location. So we have temporal lobe epilepsy, which is actually the most common focal epilepsy that's seen. And it's one of those that's amenable to surgery with considerable good outcomes. We have frontal lobe epilepsy, which is often mistaken for psychiatric conditions. Some are amenable to surgery, but the favorable outcome is less. We have juvenile myoclonic epilepsy, which is lifelong, genetic-based, and the choices of drugs specific to this disorder is crucial. And we have Lennox-Gastaut syndrome, which presents with drug-resistant seizures and progressive cognitive and behavioral decline. There is a lot of research being done in the field of Lennox-Gastaut, and there's some promising new drugs and devices. Next slide, please. So we're going to jump into, because the previous slide talked about the importance of location, we need to pause a second and talk about how epilepsy is diagnosed. We all need to begin with a really sound, good, thorough clinical assessment, which includes a complete medical history, a thorough neurological exam, blood screening, testing, which can be a routine scalp EEG or video EEG, imaging, CT, MRI, PET scan, and the importance really of identifying the seizure type if able. It's key to continue to be detectives and to really further evaluate to look for possible causes. Next slide, please. So this slide pays attention to the most common causes of epilepsy in children. 60 to 80% of the new cases that are seen in children that have epilepsy really have no obvious cause. There are children with epilepsy that have genetic causes, epilepsy that comes from head injuries or infections of the brain, referencing back to Erin's great description regarding of how we come to define the difference between seizures to get to epilepsy. We see in children the lack of oxygen to the brain causing epilepsy, hydrocephalus, and disorders of brain development. Next slide, please. So going back to our adult population, 60% of cases in the adult population are idiopathic, are unknown without any obvious cause. There are some genetic phenomena that come from some brain malformations. We have structural causes, stroke, head trauma, tumor as examples, metabolic causes, immune causes, and causes from infectious sources such as encephalitis, abscess, and neurocysticercosis. Next slide, please. This is a busy slide, but this is a slide that we ask you to pause and perhaps print and reference to in your future when you really think about that first seizure going on through epilepsy diagnosis and really drilling down to figure out what is the cause and where the recommendation of next steps for education and getting folks to providers that are able to care for them is key. At the beginning is a suspected seizure, and at the bottom of it is referral to an epileptologist at an epilepsy center. And in the middle of the slide is an array of, from the first entry of care into the emergency room, having seizures not confirmed on the one side as you see, and seizures confirmed on the other side. And we really thought this slide was a great depiction for you to reference to really see the importance as things progress, and if you cannot define whether a seizure is confirmed or not, the route that you need to go. Next slide, please. I'm going to turn the mic back to Erin for considerations in pediatrics.
So we wanted to go over some things that are a little bit different in pediatrics because they're more than just little adults, right? They are unique and have their own unique causes of epilepsy. And so one of the important things to think about is things that can cause seizures outside of epilepsy. And so we've talked a lot about the importance of defining between provoked and unprovoked, and that becomes very important in kids because we see a lot of febrile seizures in kids. It's not uncommon. It's important that families understand seizure precautions, seizure first aid, but it does not carry that epilepsy diagnosis. And so it is important to identify that. And then to consider seizure mimickers. So on that slide that Madonna just went over very well, talking about, you know, do we know if it's a seizure? And that's a really important question to ask. Kids do a lot of things. They have night terrors, they stare, they can have acid reflux, and all of that can be a concern for possible seizure. And all of that could be called something that then later does turn out to be a seizure. The other important thing to know is that if we're doing MRIs in our young kids, they're not fully myelinated yet. So that brain process that has to happen during early development hasn't occurred. And so imaging that's done before the age of 2, particularly MRI imaging, may need to be repeated after, so that when myelination is complete, we can see more detail in that scan to really understand if they are structural or not. Next slide. The other difference is thinking about our treatment considerations. So we want to be thoughtful about early surgical consideration for patients who have structural abnormalities, because when kids are young, we're working with brain plasticity, meaning that some areas of the brain may be able to pick up the slack or do functions that it wouldn't necessarily do. Now that's not a guarantee, but we do have more of that possibility in pediatrics. And so if someone has a lesion or an abnormality in their brain structure that is causing seizures, we want to be mindful of considering surgery earlier for those patients. The other thing that is true across most of pediatrics is all of our medications are dosed based on weight. So it's milligrams per kilogram per day. And so it's important to know, you may see a patient who has what seems like a very high dose or a adult size dose, but based on their weight, it may actually be an average or low dose. And so it's always important to do that math. And then we also have medications that we use more in pediatrics that you may not necessarily see in the adult population. Felbamate, we have to worry about aplastic anemia, but in pediatrics, we don't see that at the rate that they were seeing it in adults. And so it is a medication that we will still use in pediatrics, not our first line medication, but it is something that we will consider. Ethosuximide is a medication that's often used for absence epilepsy, and so that childhood absence epilepsy, that's a common cause of epilepsy in pediatrics. Ethosuximide is a common medication that you're going to see. And then some of these medications like oxcarbazepine, we just don't tend to see the side effects in pediatrics that they do in adults, and so it's something that you may see more often. Vigabatrin and ACTH and prednisolone I just put on here because those are used to manage epileptic spasms, which is that infantile spasm, seizure type. And so these are medications that you're primarily only going to see for that, but it's important to know that they exist and their utilization. And with that, I'm going to pass the mic back over to Madonna to talk more about treatment of epilepsy.
Thank you. Okay, we'll progress to the next slide, please. Thank you. So a lot of times we ask ourselves, or we have patients or families say, how do I know the treatment that I'm on is the right treatment? And what is successful epilepsy treatment? Well, ideally, it's no seizures, no side effects. And what the coaching and what our hope is for the emergence of multiple different treatments that we're seeing, and what we really want to be able to offer our patients and families to give them the best care is to really not have them settle for the status quo or good enough until they've really explored all appropriate options. They may not be doable for all people with epilepsy, and it's critical to explore shared realistic goals at the same time. It seems like I'm talking out of both sides of my mouth when I say that, but we really have to be very forefront and really explore all options that exist to be able to treat this epilepsy. It's important to make sure that successful epilepsy treatments discussions talk about prevention and treatment of comorbidities, and to also have the discussions about prevention of mortality and discuss the reality of that possibility and just be aware of the comorbidity factors. Next slide, please. So what does data say? What do we know about when treatment is not successful? Seizures do not respond to medical treatment in 30 to 40% of people. And the pie slide on the side here breaks it down for you. People with symptomatic epilepsy and causes of epilepsy most likely will have persistent continued seizures. 60% of people with new onset epilepsy do respond to the first few anti-epileptic drugs that we provide for them. So that is a really promising number of the future and some different treatments that are out there. Next slide, please. So what is drug resistance? What does that mean? Drug-resistant epilepsy, defined, is that it occurs when seizures continue despite at least 2 medication trials with appropriate drugs tried for an appropriate length of time. This cannot be determined until there is a diagnosis of epilepsy and the type is confirmed. Other factors that may affect seizure control needs to be assessed, and appropriate medications trialed need to be assessed. Next slide, please. The ideal seizure medication. Years ago, I worked with a neurologist, and he told me the ideal seizure medication was the one that worked for the patient, the one that the patient could afford, and then the one that really was able to be tolerable to be able to go through life. But what this slide depicts is that it's a broad spectrum. It works against many seizure types would be an ideal characteristics, that there would be no side effects, and that they would not be medications that you would take that would be teratogenic, that they would have no effect on bone health, weight, move, behavior, or cognition, and that this drug would be approved from the little people, that we're not just little people, as Erin said, for pediatrics, all the way up to the elderly, that the drug would be approved for all age groups, that the ideal seizure medication would be available in different formulations, including tablets, liquids, sprinkles, IV, patches. The acute seizure treatment would be in a multitude of different formulations as well, intravenous, intranasal, autoinjections, other forms, that they would be accessible at the drop of the hat, and that they would be affordable. Those are the characteristics of ideal seizure medication. Next slide, please. The trick is getting the recipe of selecting the right drug. This is dependent on seizure type and syndrome, the side effect profile, the safety factors in different age groups, the ease of use, the sexual components and effects of it and impact on reproduction, the age of a person and the impact on bone health, and the impact on comorbidities. And then you have concerns of cognition, mood, behavior, weight, and other health concerns that when you're counseling and having discussions with patients and families all come up in the selection of the right drug. Next slide, please. So there's a lot of discussion, and early on in Erin's presentation slides at the beginning, she said a very key thing, that there still are a lot of persons with epilepsy that are on the older drugs. And so this slide talks about the old versus new drugs. The older drugs have hepatic influences on pharmacokinetics, dosing, and drug interactions, and they are drugs that your patients need to have continued monitoring of serum drug levels. There are more short and long-term side effects seen, but they are less costly, and that is an important factor to keep in mind. The newer drugs, hepatic influence with less drug interactions, and the pharmacokinetics are more predictable, and with research, things are getting better all the time. There are several drugs where they're usually not needed to monitor drug levels. Side effects are less, but they are more costly when they're still under patent or are going under different trials, etc. Next slide, please. This slide talks about where do we begin. So you have a patient, you need to start them on a medication, you need to consult them regarding what to do and what this looks like, and you really need to know where you even begin. So this slide really talks about the importance to choose the best drug first, unlikely to change other AEDs. So if you can get the best drug right away, you're golden. The general guidance for many anti-epileptic drugs, as well as really any medication, is really to start low and go slow. We see that specifically in lamotrigine or Lamictal, topiramate or Topamax. Few drugs can be started really quickly. Levetiracetam or Keppra is something that we can actually start pretty quickly for titration. Dosing and rate of initiation really varies on the enzyme inducers, and the phenytoin, phenobarbital, primidone, or mycilene, carbamazepine, or tegretol, and topiramate are really examples of the enzyme inducers and non-inducers. So that really was starting medications when you're looking at the factor of the patient. This slide really depicts some different things for you to look at in regards to dosing and rate of initiation. Next slide, please. So how long do you try a drug? This slide really just talks about an appropriate trial time of medicine. And really, it really comes down to the correct drug for the seizure type and syndrome. That is really important. You want to be able to maximize the dose to efficacy and side effects, but if the patient can't tolerate going up to the next dose, they're probably going to want to stop the trial sooner than later. The use for long enough time to reach a steady state at maximum dose and to compare against baseline seizure frequency. And that's where the seizure diary and documentation and frequent office visits, if you can, and communication comes into place when you're working with the patient on a new medication and really discussing the appropriate trial time to keep them on it before switching to something else. Next slide, please. This is a slide that really shows where we all began with seizure medications with the bromides in 1857, ending on this slide with valproate or Depakote and I flip back and forth between generic and brand names. So I always am interested when I see these slides how it took a little bit longer years ago to get more drugs on the market than what it does now. But this is a nice depiction of a slide that just shows you where we began with the different drugs. Next slide, please. And then this is our newer drugs. And so at the beginning, we have Falbamate, and then we have all the way down to 2018, which is our new kid on the block, which we'll talk about, that really has gotten a lot of discussion and information out there, promising for Lennox-Gastaut, the Epidiolex. But it's a little bit quicker now when you think from the 90s to 2018 when gradual different drugs come on the market, which I think is promising for our patients as research continues to be done. Next slide, please. So this is Epidiolex, and this is just a slide, an overview slide to introduce some of you to this and to just have as a quick review for those of you that are quite aware with this medication. It is manufactured by GW Pharmaceuticals. It is grown, manufactured, and purified in the UK. This medication is plant-derived with a pharmaceutical-grade CBD, 100 milligrams of CBD per mil, 5 times more concentrated than dispensaries. And when I look at this slide and I have discussions about this drug, I think this really puts it down regarding the safety support and the information really on one slide regarding this newer medication. It is FDA approved for Dravet and Lennox-Gastaut syndrome in patients 2 years and older. There is no THC content and no euphoria reported. It is crucial and very important to monitor blood work regularly. And it is also important to know that it interacts with different drugs. And so that's a key component of patient education. And those drugs are listed there for you. Next slide, please. One also then has to pause and think about potential triggers for breakthrough seizures. So you have your patient on the right medication, they're taking the medication or they're not taking the medication, and they have breakthrough seizures. So where do those triggers come from? This slide depicts that it could come from other illness or infection. Patients could miss their medication. They could be sleep deprived, stress, or maybe they're taking some over-the-counter medications that are interacting with the medications that they're on, and perhaps they haven't let the provider know that they're taking those medications. They could be participating in alcohol or illicit drugs, and there could be multiple other factors, which goes back to our key component of assessment and really drilling down and having the conversation with the patient. Next slide, please. This slide is just another example to show you about the threshold here and to kind of reference regarding the triggers and how seizure tendency and seizure threshold can really escalate. And it depicts nicely with pictures here and arrows of how it can escalate quite quickly depending on what the tendency or source or trigger is. Next slide, please. So why change medicine? And this just is really to remind everyone that you need to change medicine. There needs to be discussion if the seizures aren't being controlled, if the side effects are not being tolerated. Of course, if there's an allergic reaction, you need to stop right away. If the patient is a woman and they're considering pregnancy, then you need to change medication. Or if there's a need for another medication for health that may interact with the medication that's on. An example of this is warfarin. If the medication is causing other health problems, then the medication should be changed. Next slide, please. So what are the other health problems? Well, this slide shows us, and we talked about that briefly in previous slides, when the patient had the concern of different medications that they could be started on. This slide really shows you how certain anti-epileptic drugs actually do have specific side effects and health problems: weight gain, weight loss, kidney stones, hyponatremia, osteopenia, osteoporosis, cognition, which is important. All of these are important, and mood and behavior. So I'll just pause for a second and let you just really absorb what you see on the slide and see how it really isn't easy. And I know everyone listening knows it's not easy to think about the ideal medication, but this really does hone in on how certain medications would not be ideal for certain populations of patients. Next slide, please. You do have to treat, and we do need to treat, persistent seizures. And when seizures are persistent, when they're not controlled, an epilepsy specialist needs to be consulted to really confirm the diagnosis and consider other options. More than one drug, additional medications, investigational surgery outlets, different imaging, the possibility of surgery, devices, ketogenic diet, all of those things listed are offered by an epilepsy specialist in a level 3 or 4 center. Treating persistent seizures involve consideration of the use of rescue therapy for seizure clusters or periods of increased seizures, and education of when to use that rescue therapy. And treating of persistent seizures for education and support to patient and family is reference to the Epilepsy Foundation and local network offices for education, support, advocacy, and training. Next slide, please. So this slide, we talked briefly about the different medications and touched a little bit on when you're pregnant or considering pregnancy. This is the use of seizure medication in females. Contraception. So different medications can lower the contraceptive component of the pill. So that's a huge education thing. Enzyme inducers and risk of birth control failure occur. And so all of this and the use of pregnancy here on this slide, talking about Depakote being the greatest risk of major birth defects and impact on child health, as well as a list of phenobarbital and topiramate being the greatest risk of major malformation. All of this discussion on this slide is key to have with a woman who has epilepsy, and to really consider this when you're talking about the whole options of seizure medications, the concerns with contraception, and the concerns of what drugs would be the safest or at the greatest risk for in pregnancy. Next slide, please. I'm now going to hand this back over to Erin.
Thank you, Madonna. So next slide, please. So we've talked a lot about who has epilepsy and what we do about epilepsy and how we can manage it for patients, but can epilepsy ever be resolved or cured? And there are a couple different situations that we would say that someone's epilepsy has resolved or been cured. One is if they have an age-dependent epilepsy syndrome. So we talked about the importance of identifying if a patient has an epilepsy syndrome, and this is part of why. So if someone has a syndrome and we know that it has a certain duration or a certain age at which it ends, that can be helpful in us identifying if a patient has a potential to outgrow their epilepsy and if that epilepsy can resolve. The other opportunity is if the patient has been seizure-free for 10 years and has been off their seizure medications for 5 years. At that point, oftentimes the epilepsy could be considered resolved. And that could happen for a number of different reasons. Epilepsy surgery is one of those options for some patients that would result in a potential cure of their epilepsy. Next slide. So when do we need to send patients to specialized epilepsy care, those level 4 epilepsy centers that Madonna was talking about? We first need to think about it if we're not sure if we have a clear diagnosis. If there's a question about, does this patient have seizures? Do they fit into an epilepsy syndrome that we're not able to identify? If we're not quite sure what's going on, the next step really should be that referral to the specialized epilepsy centers. If a patient continues to have seizures after 2 or more trials with appropriate anti-seizure medications, and like Madonna pointed out, appropriate means multiple different things. It's the right medication for the patient, it's the right dose, and it's the right medication for their seizures. So if they continue to have seizures after 2 or more medications, those patients need to see an epilepsy specialist. We also need to think about it if surgery is a possibility, or other therapies, dietary therapies, or other surgical interventions could be an option for that patient, particularly those who have a unilateral structural lesion. So if they have a lesion in one area of their brain, those are patients we definitely need to be making sure that they know about these specialized epilepsy centers so that they can be evaluated. And then for consultation, for support. If a patient is on one of the older generation anti-epileptic medications on that old list that Madonna was showing us, and maybe they're experiencing side effects and need to be transitioned to a new medication, if a patient's considering pregnancy, those are all great opportunities to make sure that patients are plugged in with an epilepsy specialist who can help manage all of that with them. Next slide. So if you have a patient that you feel like could benefit from an epilepsy center, these are resources that can help you find the next levels of epilepsy care. Obviously, the Epilepsy Foundation has a great resource to help us identify that information, as well as a number of other groups. The National Association of Epilepsy Centers does the leveling. So you heard Madonna mention a level 4 epilepsy center, and all that information is on those websites. So that's a great resource for you guys to save for later. Next slide, please. So with that, we're going to move into seizure first aid. And this is seizure first aid for everyone. And so one of the things that I always want to make sure that people understand is what we tell our families to do is what we should be doing. And so that means in the inpatient setting, in the outpatient setting, if you are out in the community and someone has a seizure, you should always do the same things. And the first thing is to stay calm. I tell my families to take a deep breath and look at their watch, because your judgment of time during a seizure is not generally accurate. And so look at your watch, stay calm, look to see if the person has a medical ID, especially if you're in a community setting. See if they have something that identifies them as a patient who has seizures or a different cause for a potential seizure for them. And then you want to keep them safe. So if there's anything harmful around them, you decide if it is safer for you to move the patient or move the object, but keep them safe, guide them away from harmful objects. You want to turn them on their side if they're not awake and aware. So that way, if they're having any saliva, if they have any vomiting, that all comes out of their mouth. It doesn't get into their airway. Don't block their airway. Don't put anything in their mouth. You can put something soft under their head. If they're wearing a necktie or have any tight collars, we want to make sure that we loosen all of that. And then don't put anything in their mouth. We don't need to put a spoon in their mouth. We don't need to put fingers in their mouths. A patient may bite their tongue, but their tongue will heal a lot faster than your fingers. And if you do try to put anything in their mouth, you risk injuring the patient. And so it's important not to do any of that. Don't give them any water, pills. Don't put anything in their mouth. And then don't restrain them. Let the movements happen, keep them safe, keep yourself safe, but don't try to hold down those movements. And then stay with them until they're awake, alert, and after the seizure is resolved. Talk with them, let them know what's going on. If you're in the community setting, make sure that the patient and the person knows, hi, I'm Erin. I'm sitting with you. We've called who we need to call. Talk with that person until they are awake and aware and can communicate with you. And most seizures last just a few minutes and they resolve on their own. But it's important that you're going to call for help if the seizure lasts more than 5 minutes. If they have multiple seizures, especially if they don't have return to baseline between those seizures. If you're concerned about their difficulty breathing, if the seizure occurs in water, if you're concerned that the person hit their head as they fell and had a seizure, they're injured or they are ill, or if they don't return to their usual state. Now that can be hard if you don't know this person, but if you find them confused, agitated, and you feel like something is wrong, trust that gut and utilize your emergency resources. Or if it's a person who has never had a seizure before, we want to make sure that patient and person is getting to the emergency services so that they can be appropriately evaluated on that great outline that Madonna went through with us earlier. Next slide. I think this is a video, but I know we're having a hard time with our audio on the videos. So I think with that, I will hand it back to Dr. Kira Kopoulos.
Great. Thanks so much, Erin. I'm going to try to play this video and just see if we're able to get through it.
Guys, give us some room. He's having a seizure. Give me some towels. Okay. Stay calm. It's gonna be fine. Help me get him on his side. All right, listen up, fellas. Before we practice, I want to go over a couple of things. First, I'd like to welcome back Michael. Yeah? Good to have you back. We all know Michael has epilepsy, and he shared his seizure with us in the game. He has something he wants to say.
Yeah, thank you all for supporting me, and thanks to Coach for knowing what to do. I'm sorry if my seizure scared you guys. It could be scary for me too. But what's even more scary is if people didn't know what to do.
So today, we are going to learn seizure first aid thanks to the Epilepsy Foundation. We're teammates, right? We take care of one another, we count on one another, and when anyone with epilepsy has a seizure in front of you, they're your teammate, and they're counting on you. So, first, stay with him, okay? Stay calm. And keep others around you calm and out of the way. Protect him. Keep him safe. It's also important to remember that the person having the seizure should be lying down and that there is nothing harmful in their way. Turn them on their side and support their head so that they're not banging it and so they don't choke. Never put anything in their mouths, and do not hold them down. Time the seizure till the very end. Okay? Knowing how long the seizure lasts is important information for the doctors to know. If the seizure lasts more than 5 minutes, call 911. When you see somebody having a seizure, you're going to feel a little powerless. But if you protect them, and if you stick with them by their side, you're doing the right thing. Okay? All right, let's practice this.
Bulldogs on 3. 1, 2, 3. Bulldogs! Go!
I would like to take this opportunity to thank Dr. Erin Feskey and Madonna Pluger for their comprehensive review of epilepsy basics in both the adult and pediatric patient populations. I would also like to spend a moment just encouraging everyone to continue to reach out to the Epilepsy Foundation online through epilepsy.com and by phone via our 24/7 helpline. Both of these foundation resources provide information, education, and support targeted for both professionals and for people living with epilepsy and their families. In addition, your local state Epilepsy Foundation offices can provide resources and support, as well as programs and services for you to share with your patients and families. And I just want to encourage people to continue to join us for future webinar learning opportunities and this nursing focus series of education, including the next webinar coming up August 8th, looking at enhancing recognition and treatment of seizure clusters and emergencies. October 3rd's webinar will look at comorbidities. And in November, early death and epilepsy will be the focus of learning for that webinar. So we hope you'll come back to join us for the entire series. I'd like to once again thank Madonna Pluger and Dr. Erin Feskey for sharing their time and their wealth of knowledge with everyone today. I would also like to thank the American Association of Neuroscience Nurses for their partnership and the CDC for their support of epilepsy learning opportunities and the work of the Epilepsy Foundation through the National Epilepsy Education and Awareness Collaborative. I'd like to thank each and every one of you for your attention and for joining us today. We hope you come back for more learning with the Epilepsy Foundation and the American Association of Neuroscience Nurses. If you have questions, you can send those questions in through the epilepsy.com website. They can be input into question and answer platform there, and they'll go to our information and resource helpline, and someone will get back to you with answers to your questions. So once again, thanks to all of you. Thank you, Madonna and Erin, and enjoy the rest of the day.